The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. Today I'm joined by Dr. Ajay Nangia. He's a professor and vice chair of urology at University of Kansas Hospital System and Medical Center. And today we're going to be talking about fertility and sexual health. Dr. Nangia, thank you so much for being here.
Hi, pleasure.
So, this is something that, at least in public school, I remember learning about like sperm and as early as fifth grade. But kind of talk to me about the life of sperm, like from the start in the body to all the way to ejaculation or nocturnal emission or whatever happens.
Sure. So, first of all, of course, sperm is made puberty onwards. There are the stem cells called spermatogonia before that in the prepubertal state. But at puberty, when all the changes that happen, voice, muscles, all the rest of it, is when sperm starts becoming present. Now, we don't exactly know if it starts a little bit before those secondary characteristics. Historically, we've not been getting semen analyses on young boys. It's kind of felt, taboo. But needless to say, there are about 5 stages of sperm production within the testicle. Everything from the spermatogonia, which are the stem cells, which are either they replenish themselves or they go on to make sperm. And then there are the primary spermatocytes, secondary spermatocytes, spermatids, and then sperm themselves, the ones with tails. Why is that important? Because they go from the 23 pairs of chromosomes, which is what all body cells have, to half the chromosomes, which is what a sperm needs to be able to then match onto 23 from the female egg that forms another human. And so that whole production from spermatogonia to mature sperm is arguably about 60 days, depending on what model you use. And some of these studies are really old. Obviously, a lot of animal models, they can't really do it on humans very well. But then it takes some time to transit through the tubular system in the testicle, the epididymis, which is the sperm duct at the back of the testicle, which I call the buff and polish. It's where the swimming ability of the sperm kind of happens because of gradient changes in the electrolytes in the epididymis, which is alkaline. And then it travels probably persistently throughout a young adult's life through contractions of the vas deferens, but that's exaggerated through the stimulation of the penis and visual auditory kind of stuff that triggers the alpha adrenergic nerves that causes the emission of the fluid basically from the vas, the seminal vesicles, which are behind the prostate, into the prostatic chamber with the bladder neck closing and the external sphincter, the one we contract when we need to pee or cough or sneeze. And it kind of builds up some pressure. Then a different set of nerves cause the contraction of that chamber to be expelled out through the tip of the penis as an ejaculation. So that whole process from testicle sperm being made to being stored behind in the epididymis on the ampulla of the vas is about 74 days. And so we kind of crudely say 90 days just to make life easier, 3-month process from production to storage of that sperm.
Wow. So that's a long time to still be going through all that process. So what comes out? Is that the mature 90 day stuff or?
Yeah, that's right. So, the replenishment is, the mechanism of all of this movement is actually still not very well understood. Here we are in the 21st century. We still don't fully understand how that propulsion system all works. But basically, 70% of a fluid that a man ejaculates is from the storage system behind the prostate called the seminal vesicles. And those are also filled with alkaline fluid and fructose, so is sugar. And that's why I think most of the sperm that a man ejaculates at any given time is not from the testicle, but mostly from the seminal vesicles. And then a small amount from the ampulla of the vas, which is sort of kind of towards the testicle a little bit. And very little fluid actually is coming from the testicle at that time. And we know this from vasectomy work, meaning that if you do a vasectomy and you snip the tubes on both sides in the scrotum, a man's semen analysis the next day actually is pretty normal. So that goes to prove if you cut off the testicle, you've still got sperm downstream. And it can go on for at least up to 10 more ejaculations. Maybe it starts declining, which there's studies that show that decline, and really goes to 0 by 20 ejaculations if you cut off the sperm from the testicle. But until that time, there's still a lot of sperm stored. So if a man ejaculates certainly more than once a day, you're going to deplete that storage. So that's not recommended when people are trying to have kids. But they did do a study a long time ago of young men and just had them, collect a specimen daily, and they actually could replete and replenish. But we do still recommend in people who have infertility or sperm count issues or even natural conception not to do it every day, but to do it every other day to have a child. So some of that physiology is known, some of it is theoretical, and some of them are from animal studies. But the most important thing, to answer your question, is if there's any insult to the human body within that 90-day period that a sperm's been made, such as fever, COVID, hot tub, binging of alcohol, drugs, anything else that's bad for the brain. So the testicular brain is the other brain, which actually is very much like this brain. And therefore, that sperm can be affected. Chemo, radiation, which is where we can bring it back to the world of testicular cancer. So within that 90-day period, if you had something bad happen, that sperm might be affected. But then even more is affected after that, because the effects on the new sperm that will be being made at day 0 of that, insult, is going to be 74 days later before that shows up, so to speak, or 90 days if we play that, that number.
That's insane. So, I mean, like when somebody gets pregnant, that really is a miracle because it has made it all the way through this journey.
Oh, it's insane. It's insane. The way I describe it to patients, and this is just in the fallopian tube. This isn't even in getting to the fallopian tube, all right? If a sperm was a blade of grass, all right, and the egg was the football, the length of the football field, 100 yards, is, just as a guess, about where the fallopian tube is, with all of the narrowings and the kind of crypts, we call it, of in and out. It's not a direct shot. That's just from the fallopian tube to the egg, all right? You've got to get up there through a fairly hostile environment, the vagina, the cervix, the uterus, even though all of those have been prepared physiologically to be receptive to this stuff. They say, used to be 1 in 70,000 sperm makes it to the fallopian tube. I think it's like 1 in 7 million from another study they did in a flushed uterus. They showed and how long did it take for the sperm that they flushed to get to where they needed to before they did the hysterectomy on this particular woman or series of women. So yeah, I mean, it's not just one sperm is enough. God, you need to have millions to get where it needs to go.
Interesting. So what does like healthy sperm look like, both to the naked eye, like a guy looking at his stuff, versus under a microscope?
So that's another very interesting question. All right. I don't think we've really learned a lot in the last 100+ years. And I'll tell you why. We don't. We've learned stuff, but not as much as we think we have. Sperm was first seen under the microscope probably in the 1800s. I think that's accurate. I hope I'm not off a little bit. But they first diagnosed or find out that the human semen has another thing in it that's moving like a fish in the 1800s. I mean, Leonardo da Vinci used to draw pictures of human sperm, and they thought the baby was in the head of the sperm or in the head of something. Right? They didn't know that in the 14th, 15th century per se, but it's been looked at under the microscope for over 100 years. And I hate to tell you, nothing much has changed in determining the shape, the length, the width of a sperm since then. I mean, we've become a little bit more accurate with measurements, but the value of knowing that is as caveman-ish or cave person-ish as then. All right. You look at a sperm and it looks okay. That's it. It looks okay. All right. There are other tests. There are functional tests that one can use, but often those functional tests cannot be applied to the sperm and then use it. We can do the genetics on the sperm. We can do DNA fragmentation. We can look at mannose binding, which is the sugar binding end. We can look at the acrosome reaction. We can even see how it penetrates a hamster egg in the lab. But how that all correlates to how that particular sperm would work in the body is, a correlation rather than an absolute knowledge. Okay, because we cannot use that actual sperm after it's been tested, because it's been tested and often with stains, and we're worried about, teratogenic, meaning causing birth defects and other things. Plus the sperm might not work. So people have tried things like weight distribution of the sperm, which you can still use the sperm to what they call flow cytometry, where they can literally under a microscope sift fluid zipping through by it, and they do that for cell sorting anyway. There's little techniques, natural fluorescence of the sperm, and even then we can look at it more scientifically by doing what they call electron microscopy. So normal microscopy is like 400 times normal looking at something in front of you, okay? So it's 400 times magnification. Now, electron microscopy is literally that. It's shooting electrons or being able to see electrons moving, and that can see right inside a sperm and what they call the infrastructure of the sperm. And how that actually correlates with how a sperm works, though, is tricky because, again, it's a matter of what percentage of sperm look like that, to the pregnancy rate. So there's a correlation, but was it a bad sperm or a good sperm that actually got someone pregnant? Who the hell knows, right? But when they do IVF now, specifically a technique called ICSI, we're still in the caveman days, where we have the embryologist look for the best looking sperm to inject into the best looking egg and then hope magic happens. And then all sorts of internal science, of much of which we don't know a lot about how embryo development happens, progression, and then sticking in the uterus. A lot of science we don't really have because it's difficult to study in the human model. Yeah,
that's crazy. So to the naked eye, like a guy at home who's like doing his sperm making and he's looking in that cup. I mean, is there a color like that he's looking for? Is there, a specific amount of cloudiness? Like what?
Right. So really just to the naked eye, most semen is white or yellowish or creamy colored. All right. Occasionally not good. But if there's some streaks of blood, I get asked to see patients with hematospermia, blood in the semen. You don't want it rusty colored, which again, unfortunately does happen in spinal cord patients, sometimes in young men post-testicular cancer who've had RPLNDs, who don't ejaculate and can't ejaculate from that nerve damage. And that can be rusty colored. The smell doesn't, as spermidine is the smell, it's kind of a disinfectant. And how quickly the semen liquefies is based on hydration, amount of fluid. There's an enzyme in the semen called PSA, prostate-specific antigen, that we all know about for prostate cancer testing. That's designed to liquefy that bolus of fluid that was used in a hydraulic system to be expelled, and that kind of then liquefies in the vagina around the cervix with this enzyme. So how easy is it? Not great, right? I mean, truthfully, ask yourself, how does an average person know what the semen should look like? A, they've seen their own, or B, God forbid, I don't really judge anybody if they've watched pornography. Truth, whatever. I mean, how do you know another man's semen is yellow and yours is white, right? I do, because I'm a urologist who does andrology and I see the specimen, so it doesn't freak me out. But an average person doesn't know that.
Yeah. You mentioned they thought that it was 1 in 7,000 sperm that it took to get pregnant. And then now they're saying like 1 in 7 million. What are the actual odds of pregnancy? Like both of somebody who has a history of testicular cancer and somebody who without the history of testicular cancer?
So that is exactly why I wanted to talk to you, because what is the difference? All right. Now, this is where infertility or fertility and testicular cancer is why I actually am very involved with testicular cancer, because the cell type in the testicle that leads to sperm production, called the germ cell, is exactly the same cell that can go wrong and form germ cell tumors, i.e., testicular cancers, right? Non-seminomatous or seminomatous, all are basically based on a germ cell, which is the rapidly multiplying cells in the testicle. And when does that happen? In men, boys, 15 to 35, and that's where we classically see testicular cancers, right? So whatever goes wrong in the testicle to cause a testicular cancer can equally cause a problem with sperm production. And that's an important concept, not only in the testicle that has the cancer, but even in the other one that has nothing felt or on ultrasound. Okay. And that's an important concept, because then people are afraid that, okay, well, should I get the sperm ahead of my removal of the testicle that has the cancer in it? And my answer is absolutely, because that one may still be making sperm, as is the other one, and your sperm count might be normal. But historically, the same problem with causing testicular cancer that also causes problems with sperm production can lead to men with testicular cancer before they have their testicle removed having a lower sperm count. Okay? And that's why it's even more important in those young men to have their sperm frozen. Okay? Now, there is a percentage of men, there was a study done where they showed men who, or boys or young adults, whatever you want to call them, males, who had low sperm counts before the removal of their one tumor or one testicle, then had their testicle removed and ended up being zero sperm. Okay? So on my soapbox, I try to teach the oncologists who are all about getting them to the OR and removing the testicle is please, please, please get as many samples frozen before the removal of the testicle, not after. And that's fine. If that's all you've got and that's all that's available, or someone's very symptomatic, then fine, try to freeze after the removal of the testicle. But there is a small percentage of men who may have zero at that point. Right. And of course, then it's very important to freeze before any chemotherapy, before any radiation, before even the abdominal surgery, probably for removal of any lymph nodes, called RPLND, retroperitoneal lymph node dissection. So I'm a huge advocate of trying to preserve sperm before any treatment. Now that means you have to find a lab, and if you've ever read the Lance Armstrong book, he struggled finding a place to go and get sperm frozen, and he managed to do it. It wasn't in the same town, but it just takes a little bit of work by the oncologist or the surgeon to know that kind of stuff. And now there are home kits that can be sent for freezing, as there are home kits to be tested for sperm numbers. But now we have the availability for a patient to be in charge, but they have to get it done fairly promptly to have the kit mailed to them, and et cetera, right? So there are avenues to make it a little easier to freeze sperm. And then post-chemo or post-radiation or post-surgery, depending on which one and what you had, is why, again, there's a risk of DNA damage to sperm, especially post-radiation and or post-chemo, that you don't want anyone to get pregnant or use that sperm that is post-treatment, which has now DNA damage on it by definition, because the intent was to kill the cancer, but in so doing can cause DNA damage of any cells, right? That's why hair falls out. And that's why the lungs can get affected. And that's, of course, why sperm can get affected. And that's why everything should ideally be done before, and then or be careful post, and use contraception for at least a year or two, and then look at the sperm numbers to see if they've returned. If they've returned is a big question, or enough, or God forbid, are lower than maybe anything could have been before the cancer treatment. and then it automatically require IVF, in vitro fertilization, which is very expensive unless it's covered by insurance.
Yeah. And, a lot of the guys that I've spoken to on this podcast, which is not nearly all the testicular cancer survivors in the world, but I mean, most of them have had the quick turnaround from like diagnosis to orchiectomy and then the sperm banking. Right. So what you're saying is like, the tide needs to change on that.
Yeah. Yeah, a lot of angst. I can totally understand it. Certainly if there's certain types of germ cell tumors that should be just dealt with quickly. The non-seminomatous germ cells, because their cell division can carry on quite rapidly in days. Okay, the seminomas, which is partly defined by the tumor markers that can, maybe it's like definitely often slower growing, that there's a little bit more time. I always taught that if you see a testicular cancer, take it out the next day or the same day, right? Especially once you get the tumor markers and the alpha fetoprotein might be up, or the HCG and the alpha fetoprotein, and definitely if the LDH is up as well, is the cell division is in the means of hours, and that's why HCG goes up within days and the alpha fetoprotein goes up in a few days, but that doubling time of those tumor markers is why we were always taught to take it out. Now, if the tumor markers are negative, it implies seminoma, and then you could maybe take a few days to make sure they get their sperm frozen and all the rest of it, and so there is a little bit of opportunity to give yourself some lead time to freeze.
Is that something that maybe like urology clinics in the future should maybe have some kind of temporary storage on site so that they could collect it right then and there?
Yeah, that's definitely, I mean, what we do, and because of where I'm at the University of Kansas Medical Center Hospital, is we already have one of our own. That's because we have our own practice in andrology, or obviously fertility. So we have a lab, and they're very good about knowing that if a patient has cancer, not just testicular cancer, but they came in for whatever, Hodgkin's or leukemia or whatever, that they are literally quite on call to have it done. If not that day, the next day. You know what I mean? And more samples, the better. And so that's the ideal world, my friend. That is what we would like to do.
Let's talk about the semen analysis, some terms that people might hear. I remember motility and I think mobility was another one. What are those specific terms that somebody might see in their semen analysis? What are good numbers for these things?
Yeah, sure. So again, I like to say these in phrases that average person who doesn't know medicine understands. It's like me being a car mechanic. I know very little about my car, really, and so they could completely hoodwink me, right? So I like to at least know what they're saying in normal ways of talking. And the way I best describe a semen analysis, and again, this is telling people who might know sporting analogy, is a semen analysis is like a baseball stats. Is a baseball batting average, or baseball stats, batting statistics, okay? Every single digit in that is at bat once, which is like a semen analysis the first time, but it's the average that matters more, right? When you have an accumulation of 2 or 3 sometimes semen analyses. There's the volume of semen. There's the pH, also how acid or alkaline the pH of the semen is, and it should be alkaline. Above 7.2, 7.4, something like that. Then there are reference values, which I'll talk about in a second. There's sperm concentration, which is how many million or not million there are per milliliter, or cc is the other word, centimeters cubed, or milliliters is milliliters, exactly. And then there's the motility, which is really just a swimming ability. Okay? And you imagine someone looking down a microscope or boats on a lake and trying to catch zipping sperm. I mean, how accurate can you catch it in a grid? Well, computers can do that a little bit better now. They can track sperm moving across a field. But within that motility, there's how rapidly moving they are, to slowly moving, to twitching, to, not moving at all. So we can subdivide it. Then there is the morphology, which is by far the weakest, and I hate that test because it's literally doing that caveman thing. You look at the length, the width, the bits and bobs made, split tails, double tails, kink neck, and the significance when you look at the 4% normal, which is the reference value, by the way, it goes to show, my goodness, that only 4% of my sperm have to be normal shapes to be normal. The answer is yes. But the problem is the validity and the value of the test is becoming questionable because people still get A, pregnant, and B, can do artificial insemination. And we don't often look at the morphology if there's all bad sperm when we do in vitro. We take the best bad-looking sperm. So morphology is starting to become a little bit annoying in terms of value. All right. Now, that's all individual stats. Now you want to know how good a swing was in baseball, right? And you get a sense of how much connectivity of that bat to ball was. So you have to stand back from a minute and look at the whole picture. And that involves what we call the total modal count, the volume multiplied by the concentration. That gives you the total number of sperm in the specimen, multiplied by the motility. That gives you what they call a total modal count. That's more useful. How many moving sperm are in that whole specimen that are either going in the vagina, to the cervix, up the uterus, or that they can process for potentially artificial insemination or IUI, intrauterine insemination? Because those numbers matter. But again, those numbers don't tell you functionality. And that's the biggest problem with semen analysis, okay? Now, the dreaded word normal, right? Normal. Or reference value. I hate the word normal. All right, I absolutely hate it, but I find myself still saying it. Reference value. So you'd think in the 21st century, again, we'd have a very robust knowledge of what the reference value of achieving a pregnancy is. Well, they did do it in 2010. Eventually, it took a while. I mean, goodness knows we've had semen analyses for at least 30, 40 years, of course, and actually more than that. 40, 50 years in terms of really measuring it. But the thing is, when they then look at it as a reference value of all blood tests, okay, how do you know what that value is in men who achieved a pregnancy under 1 year, which is a definition of infertility if you achieve if you don't get pregnant within a year, right? So they took about 800 men. We think 800 men, not just in one country, around the world. I'm like, that's pathetic, right? But needless to say, they did take a large number of men, at least around, who have different lifestyles, different genetics, different diets, and try to define what that reference value should be globally. One should really do that within a region. Maybe southern states different than northern states, maybe this diet, that diet, who the heck knows. But within your region, you should probably work out that reference value. But they have done it for an international level. And that's when the 15 million per cc or milliliter, the 1.5 cc's, the 40% swimming ability, and the 4% morphology are kind of defined as the cutoff. Now, the problem with that cutoff is this. Everybody in that study achieved a pregnancy under 1 year, okay? But statistically, they had to create a cutoff, which is statistically done at the 5%, and then the other side is 95%. Just because of statistics to create it. Because technically everybody from very low numbers to 15 million per milliliter also achieved a pregnancy under 1 year. But how many people was that? 5%. 95% of people achieved a pregnancy under 1 year above that. Okay? So what's the mean or average, or what's an average guy who actually achieves a pregnancy under 1 year? It's not 15 million per milliliter. Where you want the 50th percent, where you want the 50th percentile in the middle, 50 who got pregnant above this, 50% got pregnant below this. But what's the average, okay, that a man has? That's really about like 40 to 50 million, etc. Right? And there's the numbers higher. But so again, when we play to the test, it's saying, well, you're above 15 million, but you're not 40 million per milliliter or 50 million per milliliter. You know what I mean?
Yeah, I'd have to look back at my last semen analysis. I think I was at about 15. So, I know you said normal is not the right word to use, but I'm right on that, on that number. Let's talk about like the effects that testicular cancer treatments can have on that number. Like, obviously you said removing the testicle, somebody might have 0 after that, but like chemotherapy is going to can that change the number, or does that just change? You talked about the DNA. Like, what kind of effect does
Right,
chemo have on
right.
it?
So when I talked about people with two testicles with one testicular cancer, what their numbers could be, they could be decreased, but they could be normal, just to make that clear.
Okay.
Now, in the group of men that had a low number before the removal of the testicle, 10% of them go to zero. That's what that study showed, right? So still 90% still have sperm from the other side, which is dysfunctional, right? By the fact that the germ cells aren't working properly either, even though there's no cancer. So it doesn't mean all men who have a low number go to zero afterwards. I just want to make that very clear. So 90% of them still have sperm, which I still recommend freezing significantly, beforehand. Now, the chemo. The chemo is either going to be, a single cycle nowadays of carboplatinum, let's say, for low stage seminoma or observation, right? Observation's nice because you don't give any chemo. That's for seminoma. Or if there's a higher amount in seminoma, then maybe they'll get carboplatinum more doses, or they may get radiation, okay, for the seminoma. And that is different, but you've got to be worried about scatter to the testicles from radiation. Still, despite being shielded, because abdominal radiation is what's happening, not testicular, then you've got to still be careful from radiation. Radiation is probably a little less concern, but there is scatter radiation that can cause DNA damage to sperm and or numbers. Okay, now chemo. In the germ cell tumors, specifically non-seminomatous germ cell or bad seminoma with significant lymph nodes, then it's going to be bleomycin, etoposide, and platinum, okay? Or EP, etoposide and platinum without the bleo, because of lung issues with the bleo, and thereby it tends to be etoposide and platinum times four cycles, or BEP times 3, or sometimes BEP times 4, right? The one that's the bad one, really, predominantly for sperm is the platinum, is the cisplatinum, all right? That's just historically bad in any combination for any cancers. The bleo is more the risk of pulmonary fibrosis and the pulse in the oxygenation. Etoposide still is equally a concern on the sperm. They all do. I just have a generic statement. All chemotherapy is bad on sperm. Mm-hmm. There's no kind of ubiquitous, some is better than others. And not for the one that we clearly use in testicular cancer. Now, whether they use 3 cycles or 4, depending on the degree of lymphadenopathy, whether they then have to do, God forbid, salvage chemo, VIP often, and others, vincristine, etoposide, platinum again, if I got that right, is bad. The more the chemo, the worse the risk of and often, unfortunately, they do go to zero. The BEP times 3 may be less. I can't give you a statistic. I should probably know that, but I can't think of it off the top of my head right now. But most
it's a Sunday, you got to pass.
Oh, thank you. Yeah, no, there is a degree, and I can just sort of see the papers that might show 3 cycles versus 4. But I've come to the conclusion, you tell everybody, unfortunately, it's just my simple brain, because it's quite accurate generally, is that even 3 cycles are bad. Okay? I don't pretend to sugarcoat it in the sense, look, it's going to come back to normal. We have to assume there's a risk of it going to zero. And you don't necessarily need to recheck it until a year from now, because we're not going to use it. But yeah, I want to know recovery from chemo. Even though he could have completely no evidence of disease on the CT scan, the sperm could take, several cycles, which is 3 months, as we've discussed, to recover. And the first time you check it is a year. There's still risk of some DNA damage persistent at 1 year. And lots of people argue, and I've written a paper on this about sperm cryopreservation, infertility and sterility in cancer patients, if anyone wants to look that up. But I generally say even 2 years kind of is the safest point, when you can still say there's some risk of secondary cancers later, which is either from the chemo or, God forbid, the radiation, but sometimes from the DNA damage to the sperm. And usually not in the child or birth defects, but needless to say, we kind of limit or say that by 2 years, that risk is a lot less. And I can't even give you a percentage, because the number of people who have sperm by 2 years and then do IVF, again, would take a large number of patients to look at their outcomes from the children and years later of the children, which is still in the early days, so to speak. The kids are first lots of IVF with ICSI, with the sperm injected. They're barely coming to the age of childhood themselves, 20, right? So we have techniques that we don't know the long-term consequences despite using that sperm. But to be safe, we say 1 to 2 years. But I would tell you majority of them will be 0. Now, the one group of patients we've not discussed, before I forget, are the ones who have RPLNDs, right? Either primary, so before chemo, because there was a worry that there may be micromets, which is how we thought we would do this surgery years ago. We'd do the orchiectomy. The CT scan would be negative. It was a non-seminomatous germ cell tumor, and for the risk of 30% of micrometastases, we'd do the RPLND, retroperitoneal lymph node dissection. It started out being bilateral, without sparing the nerves, which, by the way, those nerves are the ejaculatory nerves, the alpha adrenergic nerves, that are involved not so much with ejaculation, let me rephrase that, but with emission, which is the movement of sperm from testicle to the prostatic chamber. That is because of the contraction of those nerves that are kind of milking the fluid up into that chamber. Those nerves are damaged. Then they decided that, well, we don't need to do it on both sides. We can do it on just the side of the testicle, where the cancer was, and if there's any lymph nodes that are positive there, we can look in the middle, and then we may have to go to the other side. But then they decided, well, then we can do a template, and we can try to spare those ejaculatory nerves or the alpha adrenergic nerves in the thoracolumbar trunk, and then we can save people from having a dry ejaculate. And that is definitely now happening. And they're not even doing the surgery on stage 1 or T1 disease to go look for micrometastases. They're either following them on CAT scan, or they are giving them the chemo, or like I said, or observing the tumor markers. But when they are removing the lymph nodes for bulky disease, they sometimes can still do a template. They can still do nerve sparing, but sometimes when it's super bulky, they have to go both sides, and they sometimes cannot spare the nerves, in which case, again, the men should have frozen sperm ahead of time, because their intent is to have proven that those lymph nodes are cancer, which case they will get post-RPLND chemo, okay? Or if they've had chemo and they still have disease or bulky lymph nodes or anything, then they get an RPLND after that, which is a salvage RPLND. So again, there's a double whammo on that one, right? So RPLND is not in of itself safe, but the template, as they're getting better and selective, is getting safer for ejaculation.
So you mentioned like the DNA damage and stuff, and then like the 2-year period. Is there any risk like after 2 years of there being like a miscarriage or, having a child with a birth defect with the chemo, with the sperm that's experienced chemo?
Again, when we do it with IVF, most times that's usually the case, because the numbers may not be high enough. Again, I can't quote the paper off the top of my head, because again, a lot of it, the data is not just that. Believe it or not, the birth defect data is terrible in the US. Okay, we don't have a registry that's very good. In other countries where it's a mandated coverage, like in England or Australia or France, they have that data, and the data doesn't suggest it's worse. It's just, will they maintain the pregnancy? So believe it or not, as easy as that question, and it should be easy to answer, because the number of testicular cancers that lead to post-chemo IVF ICSI is limited, it's going to take a multi-center trial. Okay, second of all, cost. The sad part about a lot of IVF is it's not covered by insurance. So then you select out people who can afford it, right? Mm-hmm. So then you take a small percentage of men, of which there's about 15,000 a year who have cancer of the testicle a year, right? A percentage of those who finish their chemo that might have the need to go to IVF. Then it becomes who can afford it. So you can see how difficult that study is, even though it's a very simple question.
Yeah.
And so I can't answer it, but again, I'd probably have to do a lit search just to see if anyone has tried to. And again, the outcome data is not forthcoming because a lot of people don't just follow miscarriage, which is most common, miscarriage and or, goes to term. They call it a take-home baby rate. Okay. But what happens after that in terms of even simple birth defects at birth to delayed discoveries, right? Not very well done, even for the bigger population of patients who have just done IVF for non-cancer reasons, if you know what I mean.
So this question might be difficult to answer because you might not have the data on it, but
yeah,
where the sperm cells are, like you mentioned, like the germ cells, and that's kind of where things go wrong and cause testicular cancer.
Yes.
If a guy gets a woman pregnant and has not yet been diagnosed, right? Like maybe it just happens in the time frame of a month, and they get pregnant, and then a month later he finds out he's got testicular cancer, but she's already, like, that sperm is already in her. Is that cell that is now in her a risk for her in the pregnancy?
No. Believe it or not, I can't say it totally dogmatically, but it comes across dogmatically because it's true. And that happens from time to time, is that the sperm was not such a damaged sperm that, because there are lots of checks and balances, believe it or not, in the formation of an embryo or correcting an embryo, even after cell division starts. It's so clever, it's insane. They know they've got repair mechanisms in the embryo. But barring that, the statistics I don't have, true. But again, the number would be low of that very specific subset. But there's no added risk because that sperm achieved the pregnancy, and not to begin, again, a very lay-term way of saying it, best one won, best sperm fertilized enough to stick and be maintained. So if there aren't any other genetic risks because of female age, or it's like Down syndrome or other things that can be non-related to cancer, which is most likely the case. So if a woman at 35, 36, 37, 40 gets pregnant, those genetic risks, independent of the testis cancer later diagnosis, it's not connected to the testis cancer or the sperm that formed that child. Again, we don't entirely know for complete transparency, but at the same time, a good question would be what the degree of sperm pre-testicular cancer discovery have DNA damage to it, or through fluoroscopic in situ hybridization, we can tell whether there's aneuploidy. That's a great question, but you're asking such a predictive question that it would be impossible, right? Yeah. Someone has to have a study going. When you then catch someone who did a sperm count, right, who then later discovered they had cancer.
Yeah, it's nearly impossible.
So almost impossible, right? First of all, the number of patients who walk into a clinic with infertility who then were diagnosed then and there with testicular cancer, then and there, is about 1%. Okay? Now, we do have patients who walk in, like maybe the survivor group, who have had testicular cancer and then come in post everything. Mm-hmm. That's not as uncommon as it should. We wish it to be, but yet again, do they have frozen sperm? That's a simple question. But the people who later develop it is very hard to predict who might get cancer, obviously. But needless to say, I have definitely found, unfortunately, twice this year, which is shocking in the scheme of things, 2 patients who came in for infertility that had testicular cancers.
Wow.
Okay. And, like I said, it's 1%. And to have 2 back-to-back, not back-to-back, but 2 in the first 3 months of the year is very unusual. But that's why they should all be evaluated. That's why men should do self-exams. And then, of course, all infertility should be worked up on the male side, right? Maybe we will pick up someone with an intratesticular lesion or microlithiasis. And again, these are very, very, uncommon situations, mm-hmm. Because the number of people with testicular cancer is not very high.
Interesting. Before we move on to the sexual health, are there any ways that a guy could increase his count after chemo? Like, can he eat specific foods?
Not really.
Okay.
Not really. All you can do is prevent them getting worse, which many times it's still avoiding the things that you should avoid beforehand, which is hot tubs, bathtubs, binging, anything that makes this brain kind of a bit fuzzy can make that brain kind of fuzzy too. So alcohol, binging, even marijuana, vaping has been debated. Lots of things are never quite clean cut like that. But other than preventing it from getting worse, making it better is very unlikely, unless they had a low T, which with or without being able to boost it with a drug called Clomid, which we'll get to when we're going to talk about sexual health in a minute. That doesn't work very well. Okay, the biggest insult was removing a testicle and getting chemo. Period. Right? Mm-hmm. The low T may be secondary. It may be because there's only one testicle, but there's no magic bullet in making the T better. The main thing is not to be on testosterone. So I'll say that. So ironically, if a guy comes in who was diagnosed with low T after his testicular cancer treatments, doctor said, put you on it, fine. Did they even check the kid, young man wanted to have children, right? Testosterone shuts down sperm production. It's like having a depot shot in a woman with a contraceptive. It shuts down sperm production. So yeah, those guys, if you stop the testosterone, you can reboot them and they can, make sperm again. But again, depends on, I don't know where the number would have been because we don't know the number before the testosterone. Mm-hmm. So that's a valuable point in of itself, I guess.
Interesting. All right. So the last thing that we were going to talk about after fertility was sexual health. And when you mentioned that as a topic, are you talking about like libido? Or are you talking about ED?
Okay. So whenever I talk about sexual health, it's all of them.
Okay.
Everything from ejaculation, everything to include libido, everything to include erectile function. So sexual is everything, right? Arguably, technically, fertility or sperm falls into that, but that kind of has its own little title of fertility. That's fine. So we already know, we talked about the post-RPLND effect or not having an effect is anejaculation or anemission. They still have contractions of climax because that's S234. That's a different nerve root, the same nerve center that causes erection. So erections stay the same after RPLND. Contractions and potentially climax can remain the same, but no fluid comes out. The dry ejaculate, they call it. And that could have backfired into the bladder because the bladder neck did not close because of those alpha adrenergic nerves not working properly, or no fluid moved out from the testicle. In those situations, it's not a big deal from a true sexual standpoint because there's still pleasure for the man. There's no fluid. Okay, that's a visual thing. Maybe it's a pressure thing. But it's a bigger problem for the fertility side. And in those cases, those men need to check the sperm hasn't backfired into their bladder after they climax, which we check the urine after ejaculation, or they need a thing called electroejaculation or a testicular biopsy. The electroejaculation is designed to stimulate, like jump starting a car, of the nerves that go to the emission process, kind of like with a probe in the rectum, which has electricity, and that has to be done under anesthesia for obvious reasons. Or we just do IVF with the biopsy of a solitary testis, right? And so that can happen, and we can get sperm from the testicle if we think there's sperm there. So that's one important part of sexual dysfunction is ejaculation. Again, erection's okay, climax is okay, pleasure should be okay, maybe a little bit diminished compared with if there was fluid there. Visual pleasure of seeing semen, unfortunately, is usually gone or very diminished. Erections, just like I said, erections should remain the same because you're not damaging the nerves either from the chemo or the radiation of the sacral nerves that cause erection, S234, okay? They're down in the tailbone. And now, the libido. Now, how I approach libido is, it is multifactorial, right? A man has just been diagnosed with cancer. He's survived, or young male, I should say, or male, has survived all of that, gone through chemo, through hell and back, come back down to earth, and now is a survivor like you are, all right? If you can get back in the groove of feeling good about yourself because you're not worrying about cancer every 5 minutes, or I know that when even times come for the CAT scan to come along, people get anxious right beforehand, right?
Mm-hmm.
And then you lose your mojo a little bit then because you're kind of anxious for other reasons, which is cancer, right? So
Mm-hmm.
there's the psychological real effect of what happens in cancer survivorship, psychological overtones and PTSD, right? So sometimes people get onto Prozac, Zoloft, which ironically can affect ejaculation also, but also can affect sex drive because it lowers the T and raises prolactin, and T being the testosterone level. Then the second one is, okay, what if it's just low T, low testosterone? One testicle, it's had chemo, the germ cells aren't working, but the Leydig cells, which are separate from the germ cells, usually are still working, which is the testosterone producing cells. But yes, if you've had chemo, often your T level can still be down from that. We have to make sure we check the hormones that go to the testicle, make sure there's not a secondary reason that can be dealt with replacing, FSH, LH, which is HCG, ironically, which is the same hormone that can go up in testicular cancer, to boost a man's testosterone, or give them Clomid, which is a selective estrogen receptor modulator to stop the feedback of estrogen to the brain, raises the hormone FSH, raises the hormone LH. LH leads to more testosterone. FSH may or may not help sperm production. And that internal rising of their own testosterone level may boost libido. Okay? Problem with it all is it's multifactorial. The PTSD, the meds, the psychological overtones, the potential issues of sleep or poor sleep, stress driving your T level, in being, unfit, sleep apnea, low thyroid level, obesity. So this drives me mental usually in my own clinic because this is where men's health is very important. I'm not the bastion of a great example of men's health, so I clearly am a work in progress also because I have the same vices that any man has. Plus, I've got some genetic predisposition. I think my side of big bone family that it is, but that's not an excuse. It's just to prove that diet and exercise isn't everything, but it's important. And sometimes if you need to supplement the T for libido, okay, energy, that's a terrible one because that's multifactorial. Foggy head, post-chemo, could be that, right? Foggy brain and loss of energy, I'm sorry, testosterone has been sold the wrong way, okay? It's multifactorial, okay? Testosterone is not cocaine. All right, repeat, it is not cocaine. You don't get a sudden buzz from it. It's not like caffeine. You don't wake up like, oh my God, I'll sniff some testosterone and the world will be great. Doesn't work like that. The anabolic nature and the androgenic nature of testosterone is it builds muscle. It can lead to these secondary male characteristics, of which erectile function and libido have been probably the two most important ones. Everything else has got not very good correlation with better T levels. That's actually the study by the European Male Aging Study from, I think, 2010 or 14 in the New England Journal, where the titration of T levels doesn't correlate with a lot of things, right? You think it does. Well, then there's a placebo effect in here too, which is up to 30%. So, yes, a young man who's had one testicle removed, the machismo of it, okay, am I in a relationship, not in a relationship? Do I want a prosthetic to boost my kind of my general morale of well-being just because it's somewhat cosmetic, along with the PTSD of the cancer and the chemo? Yeah, all of the above. I mean, my heart goes out to you guys as the survivors because you're young and, living your life early, and then something like this happens, but then we can reclaim it. And that's the important part of this conversation.
Yeah. I don't want to keep you too much longer past an hour because I know you're busy and it's a Sunday, but if anybody has listened to this and they still have questions, is there like a reputable place they can look online? Can they contact you?
Oh, they can absolutely contact me. I usually don't give my email address out just because it's inundated already. But if they ever want to contact me, I guess the best way would be our clinic number, 913-588-6146, 913-588-6146. It's a lot of trouble these days because telehealth is great, but unless we have licenses in the states that we do the telehealth, we cannot practice the telehealth remotely. So if you're in Missouri or Kansas, I do have a license in both. I could always refer you to colleagues who are in those other states because there is a large body of about 300 or so specialists who do exactly what I just talked about, who are just, they very specialize in what we have just been talking about. So I can always get you guys connected. There is the ssmr.org website, which will give you equally a map of Find a Doctor, or the smru.org, which will allow you to find another, again, doctor who is a male specialist in your region, to sound like a commercial for a second.
Awesome. Dr. Ajay Nangia, thank you so much for being on It Takes Balls.
It does take balls to be a survivor, my friend. It does. Okay. Greatness for you all. I wish you all the best. Go on, live your lives, and be special human beings and be champions of humanity because of your disease. You have had a new lease on life that gives you a new power, all right? That gives you a new power to be an advocate for goodness, kindness, medical care, and personal and family greatness. Hug everybody, love everybody, and remember what you've survived. It's made you a better person. All right. God bless you all. Take care.
Drop the mic. Thank you so much.
All right. Take care, everyone.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org. You can also follow us on social media at Testis Cancer. We're on Facebook at Testicular Cancer Awareness Foundation.